Okay, well, welcome everyone to another edition of High Rounds. Excited to have everyone here. I'm first going to introduce some infectious diseases applicants that we have today. I think we're winding down on this, and we have 4 today. We'd love to see your faces if you want to share them. No pressure to do so. But I want to welcome Dr. Nicholas Wynn, Dr. Tirajay Sadatzadeh, Dr. Morgan Barabarhan, and Dr. Vandat Sadat. I hope I did it all right with everyone's names. I sometimes like to hear them first before I say them. But we're really happy to have you here and hope you enjoy what will be a little bit of a different High Rounds for us. We have a new speaker to us, and I'm really excited to introduce Dr. Rebecka Lundgren. She is an associate adjunct professor in the Center of Gender Equity and Health in the Department of Medicine at UCSD. She is an MPH and a PhD and is an applied anthropologist with 30 years of experience in implementation science and expertise in family planning, adolescence, social norms, and gender-based violence. She currently leads global implementation science initiatives to bridge the gap between science and effective policy and practice through research, technical assistance, and catalytic support for social norms-focused sexual and reproductive health interventions. We're really excited about this presentation today, just a little bit different than we're used to hearing, and I have a feeling there's going to be a lot of interest. Rebecka, I'm going to turn it over to you, but just with a comment, if people have comments or questions, you can throw it in the chat. I will keep an eye on it, so you don't have to feel like you're looking at it, and I will only interrupt you for clarifications. Otherwise, we'll save some time for the end for discussion.
That sounds great. Thanks, Jill.
Right.
So you did all the introduction I was going to make. So I'm really excited and happy to be here with you all. Today, as you can see, I'm going to talk about social norms and their impact on clinical care. So as Jill said, a little bit different maybe from what you usually talk about on these grand rounds, but hopefully you'll find it interesting and inspiring and relevant to your work. I joined UCSD about 2 years ago now, almost. And my work is mostly in sexual and reproductive health, violence prevention, and gender. I came here from Georgetown University, where I worked previously for 30 years. Came back to San Diego because that's where my husband and I are from. So we were really eager to, move home after our kids grew up. And it's been great so far, really wonderful learning from all of you and my colleagues at the center. Most of my work has been funded by USAID, so and it's all been global. I've done very little work in the US. I started my career working in Mexico and Central America, then moved to South America, then spent about 15 years focusing on programs in India, and now primarily work in sub-Saharan Africa. So that's the kind of the context that I'm bringing to the presentation. You'll see I don't have a lot of specific HIV examples, and I'll talk about that along the way, but it's a little bit funny the way USAID works. The family planning and the HIV divisions and funds, et cetera, are very bifurcated. They're very siloed. So most of my work has been lying in the family planning area and kind of not so much focused on HIV, but I think you'll see, plenty of relevance for your work. And I do have a few areas where during the presentation, where I would really like you to ask questions, to chat, sort of to vote on things. So please use the chat box liberally. And thank you, Jill, for helping to monitor that. And I am happy to take questions along the way, but of course, we can also discuss at the end. Sorry. So let's see where. Okay, so I have no disclosures to report. And I wanted to just mention the 2 projects that I'm drawing on mostly during this presentation. So the first one is called Passages. It's a global consortium project funded by USAID. We're starting the 7th year of this project. Its focus has been to develop evidence on understanding social norms and how to address them that relate to adolescent health, mostly family planning and reproductive health. So we've been working together now for 7 years to do research, to synthesize research, to improve practice around social norms and programs that can build a more positive, enabling environment for reproductive health among adolescents. So the other project that I'm drawing on very heavily is called the Learning Collaborative to Advance Social Norms. These are 5 networks global that we have around the world. First, the Global Learning Network was the first one. It was funded by USAID, Hewlett, but primarily the Gates Foundation. And it's a community of practice, bringing together people who work in global health and development to talk about what are social norms, how do you measure them, what effects do they have on health, and how can we shift them if needed to achieve our outcomes. So that was sort of our first kind of a global community. And then we expanded to work in Nigeria, and UCSD leads this work with funding from the Gates Foundation, and also in East Africa, based in Uganda, also led by grants from the Hewlett Foundation here at UCSD, and convened locally by CARE and Makerere University. Then we also have a Francophone community of practice in West Africa and a South Asia community of practice. So, UCSD, we lead the top 2, and that we're very engaged in the other 3 through our work as part of the Passages Project. So this slide just gives you a quick overview of our goals. So it's really explicitly integrating social norms into ongoing social and behavior change initiatives, and improving program evaluation and implementation, which also includes, here we're focusing on this slide on social and behavior change, but also health services as well. So a lot of work sharing evidence, developing products together, strengthening networks, etc. So I'm going to be talking about one of the products that the Learning Collaborative developed, which is why I wanted to give you that quick overview. So I wanted to start with an introduction to social norms. And I'm not doing that just because I think most of you are more clinical researchers. Even among social and behavior change, social scientists, there's not a lot of agreement on how to talk about social norms, how to address them, and how to measure them, which is what we've really been working on for the last 5 to 7 years. So we'll start off with some quick definitions. So norms is what people in some group, because there has to be a group, believe to be normal in the group, typical, or appropriate. So some of the important things on the slide is that norms are typically unwritten and informal rules, and they're always shared within some group or reference group. They're influenced by beliefs, but largely by what other people expect us to do, what we see other people doing, and rewards and sanctions. We'll talk about that a little bit more. And then the really interesting thing about norms is that they're embedded in formal and informal institutions. So, families, churches, health institutions, professional associations, all of the institutions, schools that govern our lives. And in those institutions, through the social interaction, norms get passed on, they get learned, they get modified, they get, challenged, et cetera. So we're really looking at a very kind of interesting social interaction around the development and transmission of social norms. So this is a little bit of a more academic, formal definition. It's focusing again on norms being embedded in institutions. It also, we can think about healthcare settings having their own norms, or even research teams having our own norms. And then also, I think the policies and practices and things that you learn as part of a professional association, whether it be, I'm a member of an American Evaluation Association, or it could be as a nurse or an auxiliary nurse, or an anthropologist, we all have norms and ethics that guide our professions. So, those are sometimes the written down, formal rules, but norms are kind of behind those and also enforced by those. So I wanted to talk about one example. So you'll see, in our work, there's a lot of challenges because I work in adolescent health. So there are a lot of challenges around the way providers interact and engage and provide services to adolescents, especially around contraception. So in a number of the countries where I work, the healthcare facilities require husband consent before providing contraception. So I'm wondering, if anyone has some thoughts on what norms are influencing that. So there's a few examples. In some places, women can't get contraception without their husband's, um, approval or agreement. In other cases, women who come with their spouses, for example, get put to the front of the line because the health facility is trying to encourage male engagement in contraceptive services. So if you're thinking about a setting like that, if somebody wants to put in the chat box, what norms you think are related to this. So what are the norms that are kind of guiding the requirements at health facilities for spousal consent? You can also just unmute and say if you like. So women are viewed as property. That's a good one. Yes. And of course, they can be different in different settings. Any other ideas? Husbands control women's decisions. That's right. We have women cannot make decisions about their husbands. So all of these really are related to some kind of deep underlying what we sometimes call metanorms around gender, right? And the appropriate roles of women and men in society. Oh, and here's another one that's very relevant. Women's inherent role is to produce. So there's the issues of, women as reproducers and men as producers. So we'll keep kind of digging into these as we go on. And women depend financially on their husbands. That's another one that's, of course, really relevant because often, if there is some sort of payment for the service or if women need, money to get to the health service, it's the men are the gatekeepers often for that. Okay, so let me move on to the next slide. So there's an abundant literature base on how or on the fact that social norms influence across a number of sectors. So here on this slide, you see women's economic empowerment, hand washing, female genital cutting, child marriage, vaccination. We could add, many things. And you'll see here, I don't have HIV sort of prevention behaviors or treatment on here. And the reason why is that the HIV field globally, in particular, which is where, I work, has been very strong on social norms from the very beginning. It's been something that they've, recognized, it came out very early when we were addressing issues around stigma, because stigma is a sanction to people who are breaking some kind of norm. So there's quite an abundant literature on social norms and HIV, and also a lot on intimate partner violence and violence. So in my work, what we're trying to do in part is take those lessons learned from others and help other sectors, really appreciate the importance of norms, and that it's not just about, knowledge that you need to impart to people, but it's really addressing sort of the whole social system and the social norms. Let's see, anything else I want to say there? Yeah, so some of the work in HIV prevention and, oops, I'm getting an unstable connection. Some of the work in HIV, related to condom use, sexual behavior, testing, PrEP, quality of services, all of those are very much influenced by norms. So we talk about two different types of social norms. So, and here's an example of the two types of norms in action around the behavior of washing your hands. So a norm is always related to a behavior. So the behavior here is hand washing. And the descriptive norm is that people do what they think others are doing, right? So in this case, that's represented by seeing children washing their hands. And then what's considered appropriate, the expectations are often called injunctive norms. So that's being told by your teachers or your parents to leave the table and wash your hands. So, one of the exercises we do in social norms training is, think back to your childhood and think about ways that norms were enforced, in your family. And it's very interesting working with, folks from Uganda, from Nigeria, from Tanzania, when they talk about social norms. Often they are norms about gender, the ways that women and men were taught from an early age that they should behave, what the expectations should be. Like in this case about hand washing, I was remembering in my case, my parents weren't particularly strict about this. They really didn't have this rule. So then when I had children, I didn't pass it on either. But as I started to see other children, I was a Girl Scout leader and I would, be in other people's homes, and other parents had very different kind of rules and assumptions about the children. So that's an example of, how norms in the family structure were transmitted in a different way. So we're going to do a quiz here. So we're going to talk about descriptive and injunctive norms. And you might wonder why that matters. And it's because there's different pathways of influence. The different kinds of norms influence behavior differently. And there's different ways to address them if you'd like to shift norms. So I just want you to look at this statement. A provider who gives adolescents family planning methods will be thought of as immoral. And if you could chat in the box whether you think that's injunctive or descriptive. So we got an injunctive from Jill. Anyone? Yeah, okay, you're definitely right. So that is injunctive. And then, how about this one? Most fathers have the final say in their children's health decisions. Injunctive or descriptive? We've got Jill again on descriptive. Yeah, we've got all descriptive. Okay, so we're going to do one more. That's correct. I don't believe that mothers should make a big fuss during childbirth. Do you see that as injunctive or descriptive? Having a little more trouble with that one. Any thoughts on the third one?
Oh, I think there are 5 injunctives.
Oh, I missed those.
Are you not seeing them? Oh, that's
no, I am.
Okay.
I was just confused with the ones from before.
Yeah.
Thank you.
Yes.
Sorry.
No.
Okay, so that was actually a trick question.
Ooh.
It's not a norm. It's an attitude. So I don't believe it's a personal attitude. It's not socially driven. It's not, it's not saying that people are criticizing or looking at a provider as something being immoral. That's sort of a sanction. That's injunctive. Or people having, what other people do. Most people do this. So this is more of an internal one. And we're going to talk about that a teeny bit more. It's very common to confuse those. And also I set it up as a trick question. So on this slide, I want to talk about reference groups for a minute because social norms don't exist without a reference group. So reference group, norms are passed down and enforced by a group of people. It could be a neighborhood, it could be a work team, it could be, a family, a professional association, a religious community to which that behavior is relevant. And they define, the appropriate behaviors and norms related to that. So they can exert, of course, a considerable amount of behavior. But if we don't value those people or they're not important to us, then they're probably not going to shape our behavior. So these are people who, we listen to, we give information and advice, and they can sanction or reward our behavior. So social norms versus attitudes, which is the question we were just looking at. Social norms are different from individual attitudes. So it's not what I believe, it's what others believe. So this is the most frequent, challenge to people when we do research around social norms is a lot of our measures are actually, they think they're measuring norms, but they're really measuring attitudes. So that's an important thing to kind of get straight. So attitudes and beliefs are personal, they're individual, they're internally motivated. Of course, they're not formed in isolation. They're influenced by social context and our experience. But it is an opinion, an assumption, or a conviction that a person holds to be true. So they're formed by our internal kind of experiences, preferences, influenced by norms, of course. The way I like to keep them straight is that social norms, one is internal, the other is social and interdependent. It's just, I thought I fixed this. This should be externally motivated. So they're externally motivated, not internally motivated. And attitudes and beliefs can and often do conflict with social norms. So for example, here, I think everyone should use a mosquito net. That's my belief. That's my conviction from what I've learned. But, everyone or other people in my family find them annoying. So that's a descriptive norm. So there's often, I may believe that women and men should behave equally in all things, but the norm in my family is that men eat first. So, how people resolve those conflicts is a lot about social norms practice and how we address norms. So we're going to do another quick
Rebecka, very quickly, there was just a quick question. There's a longer comment, but I'm going to save that for later. But social networks like Facebook, can they be considered a reference group?
Definitely. So Facebook, of course, and that's some of the problem we're in today, right? Social media, there's lots of reference groups. Celebrities can be reference groups, even cartoon characters, anyone that people look to for sort of advice and to model behavior. I'm going to go ahead and answer this question now. There's about which layers have the most power to address social norms. So it's a really good question, and I just want to say very quickly is that we don't know yet. And one of the reasons we don't know is that the research on social norms is quite nascent and not very good because there's very poor measurement of social norms. So we just finished a systematic review. We started at 4,000 articles looking for interventions that influence social norms in the SRH sphere, and we came up with actually 7, and 2 of those weren't even published. And many of the ones we look at, they just don't measure norms. They measure attitudes instead. So I think men should eat first. I believe women, should listen, speak, not speak before they're heard, all of those, but they're all attitudes because they don't have the reference group involved in, the specific reference group in the measure, and they also don't have sanctions. So unfortunately, we're just, as there's been more interest in norms over the last 5 years, and there's a ton of really good qualitative data, but not so much good quantitative because, naturally these kind of constructs are very difficult to measure, these complicated social constructs. And they're very contextual. So people, sometimes we measured them with vignettes, small stories. So everything about social norms knowledge is evolving very quickly right now. So I'll do a quick, we'll talk about it some more as we move through, but I wanted to just address that. So let's try this. Is this an attitude or belief? Other nurses here encourage all their clients to get an HIV test, so I do too. So norm or attitude? Norm. That is correct. Okay, so I try to see as many patients. Seeing as many patients as possible helps you get the good shifts. So I try to see as many as I can in each day. Is attitude. Excellent. Attitude or belief. The difference between those are complicated. I do not provide condoms to young unmarried women because it will encourage them to be promiscuous. Attitude or norm? Belief. Excellent. Thank you. I think I might have one more. Oh yeah, I used to work in an outreach clinic, but my friend started to gossip about me, so I shifted to another clinic. Norm or attitude? It's not a trick question. Yes, thank you, Octavia. It's a norm. Okay, so I'm gonna, I think, shoot. Okay, I want to show a little video, but I think I forgot to enable. Maybe I can do it here.
Hey, Zuko, I got a surprise for you.
Oh, yeah?
Yeah.
Anything now?
Sandy!
Yeah,
You are? Okay.
it's just freezing.
Okay, all right. So let's go on, because actually I see where things are moving fast. So most of you know Greece, and you probably know this clip. So the question I wanted to ask you here is, what are the norms that are played? This is the scene where, he meets Sandy and his friends sort of make fun of them, and he's really acting really different. He's acting very cold and sort of, cool with her. And then they make fun of him kind of, and then, they walk away and he walks away. So my question here is, what are the norms that are at play here? And also, who is enforcing the norms? So what are the norms and who are enforcing them is my question. Men are aloof. They don't show emotion. It's enforced by their friends. Men don't really care. Machismo, and it's enforced by men and women on both sides. And that's great. And then my other question is, how do you think Danny feels in this section? What do you think Danny's conflicted? Yeah. So, you can see when you see this clip, you see him kind of look back, he looks kind of a little sad. So let's go back here. I can share so these are sort of the question here is, why do people comply with norms even if they disagree with them, right? So one thing is, so often, people usually don't even know what the norms are. So part of the process of programs to shift norms are to help people kind of voice them and become aware of them. So in this case, I think it's a good example of norms are often, people comply with them because we want to confirm or conform to our sense of social identity. And then we also saw in this example that the reference group is enforcing the norms. And sometimes, I'm not sure if that's true in this case, people have insufficient power to resist. That's often true about more vulnerable people in society, women, adolescents, etc. So I want to move on to the most important part of the presentation today is social norms and provider behavior. So most of the work on social norms, the vast majority of it, is related to what people do, what clients do, what patients do, how their context shapes their behaviors. But social norms also matter for clinical quality of care. Providers are bound by the same norms as individuals in their communities, and every health facility and professional group has their own norms or informal rules that determine their behavior. So here on this slide, I just put a few examples of how norms might influence quality care in some of the key quality of care domains. So for example, norms about how to treat clients might result in disrespectful maternity care, which is increasingly recognized as a very serious problem around the world. Norms about unmet mothers, for example, or what's appropriate behavior for women during labor. She should be quiet, she should shout, she should follow the rules, that can result in abusive behavior. On the other hand, positive, norms could protect patient confidentiality and privacy. So moving on to the second example, providers who have strong opinions shaped by norms might fail to provide unbiased counseling because they might believe that they know best for that, young woman or whoever is their client. So for example, they might think long-acting contraception really is what they should be using and not allow them to choose the method they think would be best for them. On the third example, norms about the power and the role of providers, basically providers know best, might result in contraceptive coercion. When I started working in Honduras, a good friend of mine, a doctor, told me that everything I was teaching him was so different from what he had learned because he had always learned the provider should decide. The provider's trained, you become a doctor, you study. So now you're telling me I'm supposed to listen to the woman and maybe her partner about what they want, rather than telling her what I think is best for her. So those are, norms around being a, a doctor in this case. So norms about technical competence, and might result in failure to follow protocols. We'll see an example of that here. And then, of course, if these norms are influencing the quality of care negatively, then patients, clients might not return back because they don't trust the provider or the care they're getting. So there are all ways that social norms influence quality of care. So we know that providers can enforce negative norms through judgment and disrespect, or just, the silent language, they portray to their client. I've done some quality of care work where we sort of recorded and transcribed client-provider interaction and then analyzed. It's very interesting to see sort of all the subtle cues that providers are giving that to a provider, maybe that they're not interested in them speaking, or, they're not really listening to them. So, there's plenty of quality of care literature about that. But providers, of course, can also disrupt norms by going against prevailing social expectations, or where there's positive norms, amplifying those positive norms. I've been focusing mostly on negative norms, but there are also positive norms that need to be promoted. So for a long time, in my field in sexual and reproductive health, we've problematized providers, and it's usually called provider behavior change. So, the tacit meaning here is that providers are stubborn, they're poorly trained, they're not well educated, they're lazy, they're biased. Why can't we just get them to do what we want them to? Why can't we get them to use that job aid, or provide adolescents contraception, provide respectful care to clients from a different class, ethnic group, or sexual orientation? So only recently has the discourse globally, I'm sure it may be much more advanced in the US, evolved beyond blaming providers and their lack of knowledge or poor infrastructure to understand and address the roles that their motivations, attitudes, and norms play. So, we know providers are influenced by social and institutional expectations related to their multiple roles. It's parents, children, community members, leaders, members of religious communication, as well as their role as a provider. So health systems influence behavior through the informal norms that we all kind of reproduce in our work settings, and also through policies, training, supervision, all of the things that exist in a health facility. But we also know that because people do tend to want to conform and please people they respect, peer pressure or working in peer groups can also encourage providers to offer high quality care. So, there's a vast literature on quality improvement. I think there's a lot of work that's been done on that, whole site training, peer supervision, and all of that in a way is building on the understanding that social norms matter. So what I'm going to share is an example from a product that we developed with the Learning Collaborative. It's called the Social Norms Atlas. It was developed by 70 people from around the world to introduce social norms concepts. It has 10 sector-specific sections, so technology, COVID, women's economic empowerment, and provider behavior. And then we did a cross-sector analysis talking about the norms that cut across all of those different sectors at the end. So the case study and the examples I'm going to provide to you come from the provider behavior. That was developed by folks from UCSD, from Johns Hopkins University, from Chicago, CARE, other organizations around the globe. So this slide shows 3 columns. So the column on the left are provider behaviors, and this all comes from literature. So we did a search through literature, some not all published, some great literature, came up with behaviors that are influenced by norms, attitudes related to those behaviors, and influential norms. So here you can see what we're really trying to do is show people the difference between attitudes and norms, and make it very concrete for people so that folks from different sectors can understand the influence of norms. So most of the behaviors you see on the left are positive. There's one negative, could be negative on the top, that providers deliver care based on their own experiences rather than follow established quality of care protocols. So, you can see, I won't go into each behavior here, but we've talked about some of them already in my examples. But then here you can see some things that are attitudes, things like, I believe a good provider should follow counseling guidelines. I think it's a woman's duty to be strong and not complain during labor and delivery. So those are the attitudes. And then on the right, you see some of the norms that are related to these. Some of the ones that I work with a lot are these bottom ones here. Most women in my community are mistreated. So women don't want to go for health facility delivery. They'd rather birth at home. Or providers in my community expect others will not provide contraception. So those are the kind of norms that we're dealing with, in the adolescent health area. And I'm trying to show here that many provider behaviors are influenced by their personal attitudes, but also the social norms that are established within their, work setting and also in the communities that they come from. But the good news is that just because we're influenced by these expectations, it doesn't mean that we have to follow them. So there are, many ways to address norms. And on this slide shows 5 examples that we found in the literature about, promising practices to work with norms around behavior. So you can see there's 5. So typically social norms interventions are multi-level interventions. They address not just the individual, but the peers, the facility, the hospital, the professional association. You tend to have, if you only work at the individual level, you're not shifting norms, you're just shifting their attitudes, unless you're increasing their efficacy to resist norms, which you can do. They typically, and this is true of all norms interventions, even not those related to provider behavior. They typically provide safe space for reflection, discussion groups, retreats, client review sessions, medical chart review, where you talk about and reflect in a safe way on, what's going on in patient care. Then there's some interesting work which are establishing, community mechanisms for social community accountability with providers. There's different kind of approaches that we've used globally to bring providers and communities together to address norms and improve care. The 4th one is about peer learning, quality improvement, supportive supervision, which is also channeling norms. And then the final one is, most norms are about power, who has it and how it's being enforced. So most norm shifting programs do address somehow these power disparities by, addressing gender disparities or, other biases that providers might have. So example, and in the Social Norms Atlas, for each one of these, you can click on it and then read more about the approaches that were used. So the last thing in this section is we looked across sections to see what are the metanorms or the deeply rooted determinants of behaviors, that they're probably influencing multiple behaviors, multiple sectors. And this comes close to what you were all chatting early when we were talking about those gender norms. So gender is one of those metanorms. So what you see here on this little slide are kind of a list of the quote unquote metanorms that we found. So there are norms about authority, privacy, control and violence, gender, protection, and social status. So those are norms that cut across all different areas of development and health and can influence behavior. And in the case of provider behavior, these are the norms that we saw on that earlier slide. This is basically just showing that the norms, the meta-norms that were most important are norms about authority, gender, and control and violence. So those, in terms of our work with providers, work with health facilities, those are the kind of norms that we're typically trying to engage on. So the case study here is from Nigeria. It's called Testing Before Consultation. So the guidelines in this clinic required testing for all fevers that were suspected to be malaria. But when the client got to the provider, they were kind of trying, really basing their treatment on their own diagnosis and not having the test done. So, they felt this pressure to do the same because that's what all their peers to do. Although the national guidelines required testing for all fevers. So that the problem identified was that medication was wasted and the causes, other causes of fever weren't being adequately tested. So that was the problem that the program set out to address. So they did some formative research, interviews with providers and patients and observations, and they found it wasn't the fact, mostly what you would do is teach providers the guidelines. Go in and review the guidelines, make sure they understand them, kind of reinforce them. But what they found is that providers knew what the guidelines were. They just weren't following them because of the context within which they were working. They felt that it was their role as a clinical expert, as an expert to make that decision. And because of the high client volume, they perceived that they couldn't really test everyone, so they should just decide. And they didn't want people to have to come back for a second visit, which would, kind of clog up the client flow. So this program used a process called human-centered design, working together with providers to test a new strategy. And the strategy they tested was this one, testing before consultation. So in it, all clients with fever were tested before they saw the provider. So it basically eliminated that decision for the provider. They went to the provider with the test result in hand. Then the provider spent their time exploring diagnoses, dealing with the client rather than deciding and ordering tests. That way, the testing decision was removed from the provider, but he or she still got the information they needed and there were no additional costs. So providers liked this approach. They thought it was more organized, the client flow was better. And I find this a very interesting example because what this program did was shift, solve the problem without changing providers' norms about, I'm the person who should decide. So a lot of times it's difficult to change norms. So it's better just to work around them if you can, which is what they did in this setting. So just to wrap up before questions, you can find more information about social norms on the platform on a learning collaborative, which is, you can find it here. I don't know, maybe we can send these out afterwards. We've developed a lot of resources for orienting people for social norms, diagnosing and identifying what are the relevant norms, designing social norm shifting programs, and implementing, monitoring, evaluating, and scaling up norm shifting programs. So these are some of the resources that the Social Norms Atlas includes that is very specific to provider behavior change. So if you went into the Atlas, you could access, more information on these topics. But as I said earlier, the literature is quite nascent. It's not particularly strong yet. And with that, I know, sorry, I rushed through that a little bit at the end. I hope we can have a little bit of time for, questions and discussion. So I'm going back in the chat here. You had very astute comments about Danny, that he was conflicted between his own attitudes and social norms. So that little clip is just a really good example because in a minute, it shows that process of social reinforcement. Okay, so Nettie is saying this is a big issue for HIV counseling. Right, obviously there's judgment from outsiders, but even staff from within the HIV community have strong feelings about condoms or behaviors based on their experiences, and it makes it into the communication with patients. That's, yeah, exactly right. So, I hope, even though I didn't have a lot of HIV examples, that this topic is resonating for you in terms of the kind of work that you do.
No, this is completely real. This is Nettie. This is completely relevant for HIV. This is all, that's why I asked that earlier question about we closed here on provider behavior, but also sort of just community level change and norms and, trying to decide if we have any power at all from our perspective in the in the healthcare setting, or if we really are just reliant on the greater society to change things. I feel like it's probably the latter. But we see that in HIV, certainly, when, something comes along and like PrEP came along and it was different than the norms for a lot of people in HIV, where they really wanted us to only talk about condoms. And you saw this big shift. And, in order for PrEP to become really accepted, it actually wasn't just the provider saying we should offer PrEP. It was more, I think, society shifting their perspective a little bit. I don't know if others agree with that, but I think that was an example of where our medicine slammed into social norms within the HIV community.
That resonates for me, for sure.
Yeah, Nettie, this literally came up yesterday because we just conducted a focus group of potential PrEP users, but who are not PrEP users currently. And I actually wasn't part, I wasn't part of the focus group, but what really came out was, I think a lot of the stuff that we were hearing when PrEP first came out, I don't understand why people can't use condoms. People who are taking PrEP are sluts. Like the verbiage, I think everyone was a little surprised how strong some of those norms still were for a lot of people. And then it felt like we were trying to respond to those norms. And this is what I wanted to say, is that they're really, they're norms, but there's a spectrum of norms. And which are the ones, how do you address the ones, how do you take all the norms into consideration when designing interventions that meet, that sort of address what people are thinking? And we had great conversations about it yesterday, but I think PrEP is a great example of where we really were turned on our heads, in the field of, no, but we always said condom, 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 condom. And now we're saying, well, when do you say condoms? And how does that work? And so it's a great example in my mind.
Yeah, that is a really good example. I think one of the things you mentioned there is sort of which norms matter, because, I did this really quickly, but of course there's a lot of norms. They're all kind of twisted together. So which ones do you focus on? So some of the research work we've done over the last few years is developing, they're mostly participatory research methods to kind of dig in to find out, and I prioritize which norms, your program is going to focus on, because some norms are there, but they just don't matter. They don't drive behavior. So that's a complicated piece of this. And the other thing I wanted to say, I almost showed it today, but I thought it was maybe not as relevant. We use something called the circle of care. So it's social and behavior change throughout the circle of care. So before the client comes to you, during the session, afterwards, et cetera. And then we talk about how social norms influence each phase of the circle of care. So, but it's more on social and behavior change, and I didn't know if that was kind of your area so much, but it's really true, that kind of intersection between what do we do at our health facilities and our health programs, what do we do in the communities? It's so intertwined, and then the norms that providers have themselves, so most of our programs have a lot of work on provider working with our staff or partner staff on their own biases and assumptions and norms. That's always where it kind of has to start. But it's a very time-consuming and slow process. Netta is asking if there are measures around sexual health like we do for implicit bias. Yeah, for staff to use to identify which norms and beliefs. I imagine there are. Yeah, I think there probably are. Yeah, and so
it would be nice to know, like, what we're bringing, like, oh, I'm kind of judgy about condom use, or, like, oh, I actually kind of like don't approve of this behavior and it comes across in my face or whatever. I see that a lot it's in all of our staff, and in HIV we have a lot of support staff, people from the community, lots of folks, and we sort of think like we might be above all of that, and absolutely we're not. So the implicit bias has opened a lot of eyes, like, oh, I'm not above that. And I think probably for sexual health it's the same. We all think, oh, we're sexual health doctors, we're really open, but probably not.
Oh yeah, I think we all of course all have a lot of biases. I work with Planned Parenthood here in San Diego, but also in around California, around a program to engage men more in family planning services. And I thought it was going to be a simple kind of change, but it was really totally against most providers' kind of paradigm. It's like, this is about women's rights, it's women's space, You know, even the idea of asking a woman what her partner thinks about contraception and how he might influence was even seen as taking away her time and her space. So, you know, it's another example of, you know, and they wouldn't have said that until we started working together and we saw that we have these, you know, really kind of unsurface assumptions. So that's, I think the idea about implicit bias is an interesting one. Alan, I see you have your hand up.
Yes, I wondered whether you have begun to apply these concepts to COVID hesitancy around masks and vaccines and so on, and what insights you can offer about that.
Yeah, we have begun for sure. And there is one section of this Social Norms Atlas is on COVID. So yeah, it's, you know, it again is kind of nascent, but as it's very clear, I think, to all of you that masculinity has played a big role in it. You know, if you look at some of the global leaders who are such anti-masking kind of proponents, you know, and there's a lot of sort of masculinity issues about real men don't wear masks. You know, there's programs in South Africa, I think it is, that have masks that say that, you know, like real men wear masks, you know, and Swahili, you know, there's different kinds of ways. So a lot of programs around the world have already kind of seized on that gender piece of it around masking. But there's a lot of other pieces to it, not just gender. So yeah, there is, when we developed this atlas about a year ago. So even as we were like editing the final version, new articles on social norms and COVID were coming out, but there is, if you do go to the atlas, there's a, you know, a whole list of resources on it.
Thank you.
And it's such, I mean, looking at the US, it's such a case study for norms and COVID. I mean, it's all I see when I look at COVID, you know, norms around masks, norms about vaccinations, you know, social pressure, sanctions, you know, it's all there. It's kind of very clear for us to see. And there's been some interesting work on what they call tight and loose societies. So there's some places where norms are very tight, you know, think about some Asian countries and countries like our own where norms are very loose. And typically the kind of change you can bring about, you know, it can be easier in looser societies. I mean, or harder, right? So, you know, if you can just mandate something in some context, people do it. That's certainly not the case in our context, I think. Other questions, comments? I'm looking at someone in the chat. Oh yeah, you were saying Alan had a great question. You know, what happens to me is I just start seeing norms everywhere, as I think happens to all of us when we start working on a research topic. You know, I didn't talk much about sanctions, which are really important. And I think about them a lot when I think about HIV because, you know, a lot of stigma, for example, where some of the really great work, you know, came from is a sanction. So, you know, gossip, criticizing, you know, exclusion, making people sit separate, you know, all those things are ways, really easy ways of seeing social norms in action. Sometimes people advocate using those as a measure. If there's no sanction for a certain behavior, probably the norm isn't, you know, really guiding behavior. So that's one way you can kind of see what norms might be relevant.
I was giving a talk yesterday on gender inclusive healthcare to our urology group. And a norm that comes up a lot that's really hard is, you know, how you address people and things that came from how you were raised. So calling people Mr. and Mrs., and that's a sign of respect, and that's right. A norm that you use. And when you want to be as inclusive as possible, those are not assumptions you should make and really shouldn't be doing it at all. And so there's a big discussion on how do you undo it, and should you undo it if it's something that actually, you know, you believe and you'd like to do when it fits and it's appropriate. So I think this goes back to, you know, what norms matter, what needs to be sort of addressed and altered or looked at differently, and how do you maintain some aspects of norms that maybe are important for some people.
That's right.
But need to be altered to make sure that you're including other people. It was one question. I was like, oh, this is
So
taking
interesting.
all over the place.
You know, Jill, that raises something really important that I didn't even mention, are sort of ethical issues about norm shifting programs. So, you know, in my work, mostly we're going into other communities, you know, coming in as an extra, but any kind of norm shifting work, there's a lot of ethical debate about who should decide which norms are valued, how should they be promoted. So, you know, good social norms shifting practice is always kind of rooted in the community, having those discussions and leading the change, because it's a very tricky and slippery slope for sure.
Yeah. Well, it's almost 9 o'clock. I don't know if anyone else has any questions or comments. I think this was such a thought-provoking talk, and really, again, I was saying, oh, outside of what we do, but completely applicable to what we do, just different than our sort of typical talks here. And I think it was great, and will leave a lot of us with things to think about, and ways that we practice and approach patients and community members, and just how we, you know, interact ourselves. So thank you so much.
It was a pleasure. It's so much fun to talk to you all. And if you have any questions, you know, want my resources, do feel free to reach out.
Thank you so much. And I'm sure we're going to have you back at some point in the future. So thanks
Well, have
so
a
much.
great day. Bye, everybody. Take care.
Bye, everyone.